Okay, Suzanne.
Thank you very much, Chris. It looks like people are beginning to gather on this Friday afternoon. Wherever you are in the world, we did in fact have people from all over the world registering for this webinar. Again, it's Friday afternoon somewhere in the world. Everywhere in the world, actually, isn't it? No, I guess in some places it might even be Saturday.
It's the weekend.
It's a TGIF, isn't it? So I still see people coming on, Chris and Cindy, so let's give it another minute or two. Does that sound okay?
Yes.
Sounds good.
Okay, well, I think everybody's slowly but surely joining us, and it is now time for us to begin our Friday afternoon webinar, or we'll call this one the TGIF webinar from the CFS Association. Thank you, everyone, for joining us. This is our 6th or 7th webinar for this year, and over the next couple of months we hope to host a couple more interesting webinar series, and stay tuned for those. We'll be sending out the announcements. Chris, can you go to the next slide? For those of you who don't recognize my voice, my name is Suzanne Vernon, and I'm the dark-haired big head picture on the left. I'm the scientific director for the CFS Association. I've been the scientific director since 2007, going on 5.5 years now with the CFS Association. This afternoon I have the great honor and pleasure of introducing my colleague and my friend, Dr. Lucinda Bateman, who will be talking to us about combining research and clinical experience to manage ME/CFS. Cindy's presentation will be about an hour and 15 minutes, and it's a great presentation. I heard it for the first time a couple of weeks ago when Dr. Bateman and myself were hosted by the Rocky Mountain Chronic Fatigue Association. Tim Smith and the RMCFA hosted us for an afternoon in Denver, and it was a very important and interesting presentation that Cindy had given, and I think she actually put this together somewhat new earlier in the year to present to, I think it's a Canadian group, right, Cindy?
Yes.
And it was also very well received there too. So it's super rich with information and insight and experience and wisdom. And again, we're very happy to bring it to you. A little bit of housekeeping issues. You are able to submit questions through the control panel that you see on your right. Since Cindy's presentation is pretty packed, what we will do is we will gather those questions and group them together so that I can give her some of those questions, ask her some of those questions at the end if we have time. If we don't have time, again, I will collate them, and Cindy and I will get together later on and figure out how we can actually address those, and perhaps we will address them in Research First blog post. Cindy is in Salt Lake City, Utah. I'm in Salida, Colorado, and Chris, our organizer, is in Charlotte, North Carolina. So we're all in 3 different places, just as everyone participating is in a different place in the world. We can't see each other. We can't see you. We can only see the screen. So it is somewhat of a bizarre experience, but Cindy is just an excellent presenter, so I think she's going to be able to visualize all of us listening and very anxious to learn what it is that she has to say. So without further ado, Dr. Cindy Bateman, take it away. Chris, you want to hand over the controls?
Okay, let me make sure I've got this all set up correctly. I'm here with my water bottle and my 4 pairs of glasses for each distance away. So hopefully I can read all my notes and share my thoughts with you today. It is a pleasure to come and share some ideas about how in our clinic I combine research and my clinical experience to try to manage these difficult problems. And when I first gave this talk, it was actually on May 12th, so it was ME/CFS Awareness Day to my Canadian audience. So I think it's a great chance to develop it and pass it on to more people if it's helpful. Let me just get going here. So I want you to just look at this picture here. This is the picture of illness. These are notes from my clinic. This is the actual pain diagram and the symptom scores from a sufferer in my office. This is the way a patient feels. This is the way a patient presents to their primary care, although this may not be well communicated, and the way they present in my office. Of course, there are many, many more symptoms than this, but these are some of the symptoms we score, and see if you can see yourself in this picture. This, on the other hand, is a very complicated slide that might reflect what's in the mind of a CFS clinician or a researcher as we're trying to tease through these symptoms. And on the right, Suzanne, can you see my pointer while I'm talking, or my mouse, or not?
Yes, I can.
So I'm the only, okay. So now I lost my mouse anyway. So let me go back to that slide. So on the right on this slide, I've listed some of the many areas of research that we have supporting what we know from the research standpoint about ME/CFS. The rest of the picture is sort of a hypothetical model of the way we're looking at this illness, combining neuroendocrine factors, immune modulators, immune mediators, neurotransmitters, as an illness that is somewhat lowers our resilience for stress, both physically and mentally and emotionally, and impacts many, many systems and symptoms in the body: the brain, the musculoskeletal system, the GI tract, the immune system, the cardiovascular system, and the HPA axis, or the hypothalamic pituitary adrenal axis. And these systems all interact with each other, and you can see from the color code here that I've tried to associate some of the research findings with some areas of the body that are affected by this illness. So I'm going to come back to this slide many times during the presentation, so you don't need to understand it all right now. But what I'd like to do in this presentation is help you understand how, as clinicians and as patients, we want to achieve the best management of this illness. And as a clinician, I think that I'd like to make the argument that supportive care in the context of our current research is probably one of the best ways to achieve stability and management. And why is it important? Well, it's important because it may place you, the patient, in the best position to reduce symptoms and increase your quality of life, but also put you in the best position to actually improve, to heal and recover, which improves your prognosis and may give you a chance to participate in research. When we screen for research, we have to pick up patients that are stable, have well-controlled comorbidities, and are not on too many medications or have symptoms that are disabling them to the point that they can't participate in research. And also, good management puts you in a position to benefit from primary treatment as it becomes available. So it's very, very important that we understand the physiology of the illness based on the research we have, and leverage that and use that into designing a treatment plan. So what I'd like to do in the following slides is outline the steps that we follow in our clinic, combining research and clinical intuition, or our experience, to try to devise the best diagnostic and treatment plan for patients. And we're going to go through these individually. I'm going to start with number 1, which is a big job, but that is to identify and treat all other medical conditions, whether they're comorbid, that means they're kind of combined or allied or connected to the illness some way, or something that commonly occurs with it, or an underlying illness that might actually be the real illness causing the symptoms. And this is a big job. This is something that needs to happen at the beginning of your workup with each physician, but at any stage along the course of your illness where there may be another illness entering in, or the illness, the diagnosis that you of CFS or ME/CFS needs to be re-examined. This is a big list. So on the right, I have a list of common medical illnesses by system or by specialty that might present with quite significant fatigue. So neurologic problems, some kind of a malignancy, whether it's active or metastatic, or even the treatment of a malignancy, autoimmune or inflammatory illnesses, infections, cardiopulmonary problems, coronary disease or some kind of lung problem, metabolic illnesses, endocrine or hormone problems. And I've included fibromyalgia on this list because we're having a bigger understanding, a more broad understanding of central sensitivity and pain amplification, particularly in patients that have only that problem, and treatment of the primary pain amplification is very, very helpful for improving how they feel. So these are part of the differential diagnosis that must be addressed with a team of medical providers, your primary care provider and other people who are helping you. And those are not the only things that can cause fatigue. We all know that mental health issues can contribute to fatigue, and there may be primary underlying disorders, but depression, grief, anxiety, worry are common secondary mood symptoms that happen to almost everyone with chronic illness, not just ME/CFS, but others. Then there are a little more subtle factors that we forget to pay attention to how medications might contribute to fatigue, how deconditioning or becoming weak makes it hard to get around and adds to the fatigue, just being stressed or overextended, having poor sleep, suppressing your HPA axis from stress, poor nutrition, and just unrelenting pain becomes exhausting. Yet these are factors that can be addressed individually by a physician who is not a specialist in chronic fatigue syndrome. And then in the middle, I put the one we all hate to think about, and that is after you've been sick for a decade, you are a decade older, and as we age, there's an element of fatigue and sleep disturbance and other things that come along with age. So this is packed into one slide, some of the many types of illnesses that need to be considered with all your health care providers, of course beyond the scope of this talk, talking about in very much detail. Number 2, and probably what I would call number 1 in the actual management of ME/CFS, is the importance of learning how to pace your activity to reduce the severity and duration of post-exertional malaise, or often called post-exertional neuroimmune exhaustion. Now, why is this important? Well, let me describe it first. I put my own definition to this: the physiologic response to activity, either physical or mental activity, that exceeds the currently tolerable level or threshold, and that results in a relapse of illness symptoms. So post-exertional malaise is a relapse of the illness, and some people are in a constant state of post-exertional malaise from pushing hard and having high symptoms. And Jenny Spatilla put a much more descriptive paragraph here about what it feels like to experience post-exertional malaise, and maybe you've read that in her series about post-exertional malaise on the CFS website. Now, I gained an appreciation of post-exertional malaise from my research with Kathy and Alan Light in the study of gene expression results after exercise, and their results have been published a few times, first in 2009 in the Journal of Pain, actually put on the cover, and then again in the Journal of Internal Medicine in 2011. And I thought, although many of you have seen these before, as a preface to my remarks about some of the individual studies, I want to remind you what this study they published showed. And they chose to look at this set of gene expression markers that span the sensory receptors, adrenergic and immune receptors. And you don't really need to understand all these receptors to gain some appreciation of this work, because what they did is took normal controls, CFS patients, and another disease state, and drew all of these biomarkers before exercise, and at the place of this blue arrow, the patients in this group, the control group, exercised for 25 minutes on an aerodynamic 70% of predicted heart rate. Then their blood was drawn for exercise at 30 minutes, 8 hours, 24, and 48 hours. You can see there's not too much activity of gene expression in the normal patients. When we asked the CFS patients, both those with and without pain or meeting fibromyalgia criteria, you can see that the gene expression response, or the increase or upregulation of these biomarkers, was very definite at each of those four blood draws after exercise. And when this study was done in several different groups, this is an example of multiple sclerosis patients with fatigue who had baseline levels, exercised for 25 minutes at the point of the arrow, and then had their blood drawn 4 times. You can see that it's nothing like the gene expression markers in our group of CFS patients. This was the first 20 patients. There were only 19 because one of them had a problem with the development of the lab. But this is, and then there was one more group where the patients, the control patients, exercised at very high intensity for the 25 minutes and had their gene expression markers measured over the 4 time periods. So later on, we were able to analyze the results of our patients, and what we began to realize was that about 2/3 of the patients had a gene expression profile that showed upregulation of most of the genes, and about 1/3 had a single important and statistically significant finding of the alpha-2A receptors going down in the 4 blood draws after a single bout of exercise. And this held true. This is the group of patients who had fatigue only with no pain. And here's the group that had fatigue and enough pain to qualify for fibromyalgia criteria. And you can see, again, the 2/3, 1/3 split. But this group has the addition of that blue bar, and we've come to feel like that the ASIC3 receptors are one of the gene expression markers that are associated with the addition of pain. So you can see here's that group without the pain, mostly this. We think these bars right here are related to deconditioning. And then when they meet fibro criteria, this alpha-2A decreased group adds the pain bar, and those bars are over here too. So we're interested in these markers and what they might mean as a biomarker for CFS. But what's especially interesting to me is that as a clinician, I was able to pull out the individual results of patients in my clinic. What we were looking at originally were the results of the group. But individually, here is a 20-year-old male who became ill as a teenager. He's a kind of a budding geologist and met criteria for CFS, fibromyalgia with significant orthostatic intolerance. And here is the gene expression panel at the 4 points of blood draw after the exercise. So here's baseline, compared to our large control group that you can see had a much less dramatic gene expression profile. So this young man falls into mostly the alpha-2A reduction group, and we were able to apply some of the things we learned to designing treatment for him. The next 2 slides show 2 50-year-old men who both severely disabled. This patient has severe orthostatic intolerance and cognitive dysfunction, and you can see he was actually the prototype for the one we discovered had this alpha-2A reduction. And compare this to another male in his 50s, equally ill, disabled, who with horrible post-exertional malaise, cognitive issues, orthostatic intolerance, and he has a much different picture of gene expression across the 4 blood draws compared to the other 50-year-old male and compared to our control group. When these two men walk into my office, I actually could not predict their gene expression based on the way they walk into the office. Both equally ill, both meet all the CFS criteria, and yet in some ways we may be able to use some of these gene expression markers to tailor their treatment. Now this is in the very, very early stages, and what we've learned by doing many more individual gene expression studies is that these studies are not necessarily a fingerprint of the illness itself, but a fingerprint of a moment in time for that individual patient. We've looked at patients 2 or 3 times, the same patient undergoing the study 2 or 3 times, and the gene expression panel may look different each time they're studied because of the multiple factors that may affect gene expression. This is a 23-year-old woman who is able to teach music lessons in her home 10 to 15 hours a week. She's been able to get married. She's one of the patients that we put on Valsite, this is unrelated to this gene expression study, who got maybe a little bit of improvement but had some significant side effects from the drug. And you can see that she has a very distinct gene expression profile that shows without a doubt that she is a patient with this illness and doesn't look anything like the control patients. This is a 22-year-old woman who became ill in her late teens. She's getting on with her life. She's married. She recently gave birth to her second child, but she is so ill that she's unable to care for her children alone in the home and has help all of the time that she's home with her children to help. She's very happy. She's living with her illness, and you can see that her gene expression pattern has a combination of upregulation and the alpha-2A decrease as well compared to the controls. This is a middle-aged male. I like to throw this one in because his wife had to go back, train, and work for their family. They have several children. He has to stay home. Honestly, when I first met him, I wasn't quite sure if I knew what his illness was, and I felt like maybe he was suffering from depression or had some other problem. But once he underwent the gene expression studies, it became very clear to me the extent of his illness, and allowed us to offer much more individualized supportive care for him, along with the treatment of some of his other issues. This is a male
Cindy?
in his 40s.
Hey,
Yes.
Cindy?
Yes.
Can you explain what you mean by up-regulation or down-regulation?
Okay, and maybe it would be better to just say increase and decrease in the amount of these markers in the blood. So upregulation would mean relative to the level before exercise, the level of that gene became much higher each time it was measured these 4 times. And I think the fact that it was measured 4 times and that you can see a consistent pattern supports the validity of these as a marker of some type of physiology. In some patients, the value became much lower. Let's see if I can go back. So compared to baseline, the alpha-2A receptor amount was much lower when it was measured at each of these time periods. Does that help explain?
Yep, it does.
Okay. All right. So just a few more, because I think seeing individuals gives this some life. This is a male in his 50s who was a very successful financial planner, now struggles with just managing his household, helping his family members, dealing with his own chronic illness. The 30-minute values are not there because there was an issue with the blood, so we weren't able to process the first set of samples, but we have his baseline values and then 3 different blood draws showing the same pattern of gene expression. Very, very high values that actually went off the chart above the 10-fold level at those 3 blood draw points after exercise. I actually talked to this person very recently, and he told me that he became very ill and had a major relapse after undergoing this exercise testing and would hesitate before going back to do it again. But I think I've actually talked him into it because he's feeling a little better, and we would like to get more serial measurements of his gene expression if we can, so we can understand better what it is these findings are telling us. This is interesting because this is a woman in my practice in her 60s with very classic CFS. She was actually an Ampligen patient at one point. She is able to manage alone. Her illness is, I would say, moderate at this point, and she is, because she lives alone, can control almost every variable in her life, and she's a master of pacing and good health practices. And when she went to do the exercise test, there are significant differences between her value and those of the controls. If you would just ignore those pink values right there, because we think those bars represent deconditioning, and we asked for controls who were not fit or exercising, you can see that her values, there's clear upward trend of the alpha-2A receptors right there at each measurement. She clearly has illness, but has a well-managed, stable form of CFS after many, many years. Well, the next two slides I wanted to show you that we can take research such as gene expression and combine it with other studies that have been done that have shown value in the management of CFS. For example, this patient who is was in his mid-20s at the time of this study, had onset of CFS in childhood. He has about 6 to 12 hours of function in him each week. We have very strong data on him using tilt table testing, showing severe changes under the conditions of a tilt table test, and he underwent cardiopulmonary exercise testing with values that were very, very abnormal. And he shows a similar pattern to that last patient, that his alpha-2A receptors increase sequentially, peaking at 48 hours. It would have been nice to draw his blood and check gene expression for an entire week so we could see when those values gradually improved and came down. But I can tell you that when we did his cardiopulmonary exercise testing, his blood pressure only increased by 5 points at peak exercise compared to his rest values. Very, very abnormal findings. And he also had a normal treadmill test he was referred to the cardiologist actually after his cardiopulmonary findings because they were worried he had another problem. But further assessment showed that his only known illness is his chronic fatigue syndrome. This is another woman that we have a combination of gene expression findings. Here she is as a good example of that 1/3 of results we see with a significant decrease in this one receptor, alpha-2A receptor, over the 4 blood draws. And we have cardiopulmonary serial day testing in her. So she had a max cardiopulmonary test on one day with a VO2 max of 11, and again on the very next day showing that it was difficult for her to reproduce, or she was physiologically unable to reproduce the same VO2 max, which we think of as a signature for CFS based on some of the research. So by combining research modalities, we can learn even more about this illness, and as these tests become more clinically available, we may be able to use them to guide our clinical interventions. Right now, unfortunately, many of these tests are only available on a research basis, but they're still very important for moving the field forward and for teaching us about the physiology of the illness.
Cindy, do you know if anyone if there are other researchers or other studies that have validated this gene expression pattern?
I know there are studies ongoing, but I have not been able to review the results of these confirmatory studies. So hopefully those will become more available. But I do want to say that what looked like a really clear signal when you lump all the patients together, as we look at individual results, we can see there's a broad variability of how any one gene expression result is for a given patient at a given time. Mm-hmm. So we may use gene expression more to teach us about the physiology of the illness. They may be more an expression of a symptom at any given time, and there are a number of variables I can discuss that probably impact how the gene expression panel looks after exercise, even for one person, depending on how long they've been sick, what medications they're on, how tired they are before they go in to do the gene expression study. You know, if they start at a well baseline or a sick baseline, how fit they are before they engage in the exercise. Some people can't tolerate any exercise. Our studies showed that our most sick people had the biggest changes in gene expression, either really big increases or decreases compared to the less sick patients. But we have a lot to learn, and this is simply going to be a tool to give us more objective information for unraveling this mystery. And these two slides may help reinforce that. These are two exercise results on a single patient at different times. On the right is an exercise study when the patient was in her native state without the addition of the drug we were studying. I'll tell you about that in a minute. Here are the baseline values, and you can assume the exercise was right here. And then here are these, in this case there were 3 blood draws, 8 hours, 24, and 48 hours after the exercise. You could see a big escalation in this gene right here that we believe is related to pain. So this is a patient that met fibromyalgia criteria, and this patient has the alpha-2A decrease. I'm just pointing out these because these are the ones that we're starting to track. But in the newer gene expression studies being done by the Lights, they're looking at 2 or 3 times the number of gene expression markers across many other systems. So it's possible we're not even looking at the most predictive gene yet, and we need to look more into that. But back to this on the left is the study of the same patient at a different time on a fibromyalgia drug. And this was a drug we are studying in a research protocol. I'm not going to tell you what the drug was because this is not yet published, but I will say this is a drug approved for fibromyalgia. Same patient. Here's the baseline level, which we always consider 0, and then 8 hours, 24, and 48 hours after exercise, you can see a very different gene expression panel on the drug compared to when she did the study not on the drug. And in particular, the expression of these receptors right here that we think are related to the pain are very small, and this correlates with her improvement in pain on this drug. Here's a second patient who was part of this protocol. Here's the patient on placebo, baseline, 3 different blood draws these arrows are pointing out these 2 elevations right here that we think are related to pain. Here is the exercise study and gene expression results when this same patient was on the fibromyalgia drug. Looks completely different. You see how important it is how a drug can change gene expression. And if this could be harnessed and refined, we might be able to use gene expression to assess the benefit of a drug. And this patient felt much better on this drug. Now, not everybody does well on this drug. Some people do not do well at all on this drug. In fact, we had a number of people on this study. Some hated being on the drug. But either way, whether they got clinical benefit or not, there's a signature with gene expression that should help us learn how to interpret some of these symptoms.
So Cindy, the ones that hated being on the drug, did they benefit, even though their gene expression, they didn't?
No, and that's kind of what I intend, is that there were people who did not perceive a clinical benefit from the drug. So that's a good example of how gene expression is neither positive nor negative. It doesn't show necessarily illness. It may just show change, or a change in a symptom, or expression of a certain symptom, but not necessarily clinical improvement on the whole. And those are the things we need to learn about what each of these genes, what they are telling us compared to baseline. And the importance of these studies to me, a couple things. One is, remember, all of these findings are an expression of post-exertional malaise. So I'm putting them in this section because after doing all this research, I became convinced that post-exertional malaise was a bad place for people to be. And the gene expression demonstrates that the symptoms become much higher. It's supported by the gene expression findings. And I think we should do the best we can to stay out of that place. I tell patients in coaching them about post-exertional malaise to stay out of, to not raise their bars and try to keep, try to do the amount of activity that you can recover from in a day or after a night of rest. Because if, this is not the best one to show it, but at baseline, here's the exercise. If you exercise again here at the 24-hour mark, you superimpose additional physiologic response on top of what happened the day before. If you exercise on the next day, again, this is why when people engage in serial activity, why retest using cardiopulmonary exercise testing shows that you actually worsen the physiology of the illness by pushing hard enough to create disease symptoms. Yeah. So one of the biggest values of gene expression for me, besides being an objective marker of this illness, really demonstrating that people have a real illness, is to show that exercising excessively or beyond what feels natural can definitely cause disease relapse. So I put this under number 2, which is really number 1 of management of ME/CFS. I think of pacing as a primary intervention to control post-exertional malaise. And these are just some insights I have. Whether or not these will prove to be true, these are my own clinical intuition pearls, is that preventive pacing is helpful. Sometimes people just go until they drop and then rest until they're better. I think it's better to avoid getting into that really ill place and rest up and do a little and rest a little, rather than causing severe post-exertional malaise that takes a long time to recover from, sometimes never. Post-exertional malaise can be related to mental or physical exertion, and also, I believe, from orthostatic or upright stress. So people who stay up too long or stand too long can have post-exertional malaise, and we'll talk a little more about the physiology. I think the prevention or recovery position is lying down, resting, hydrating, resting the brain from all the stimuli. I think people instinctively know that. And so you can do a little bit and then lie down, rest, do these things, and allow your post-exertional malaise to resolve before it gets too big, and then you're able to go do more activity. And, pacing, again, can be done in small increments all day long. I have one patient who's really been good at this, and this is her formula. I'm not saying everybody has to do this formula, but she does a 1-to-1 ratio of upright activity to rest. That means she would do 30 minutes, for example, 30 minutes of upright activity, walking around the house, doing her errands, and then rest, lying down in this prevention recovery position for 30 minutes. If she does a more intense activity like shopping or doing something that is more likely to cause her relapse, she does a 1-to-2 ratio of activity to rest. So she would do, for example, 15 minutes of the activity followed by 30 minutes of recovery. So this is her formula. Everybody has to figure out their formula. Some people can do way more, some people way less. But the principle is that pacing is a very important tool. And I believe that the more time you spend not in relapse or with the absence or resolution of post-exertional malaise symptoms, the more time you have to recover and to improve.
Hey, Cindy.
So, yes.
You used the term supportive care on one of the slides. Can you explain what you mean by supportive care?
Yes, and that's probably, this is a good time to do it. By supportive care, I mean we offer the body support along all aspects as opposed to a primary treatment for the disease. So, for example, because, well, and we have to do this because we don't have a primary treatment. If we had an antiviral drug or an immune modulating drug or something we could use that would knock this illness down and allow people to recover because the primary issue is being treated, we wouldn't have to use as much supportive care. But my argument is we need to provide good supportive care, and we could go back to that first slide, so that you are in the best position to live your life, to have fewer symptoms, and to be ready to participate in research or be primed for the primary treatments when they come. So supportive care is sometimes, in primary care we'll say, oh, you've got CFS, there's not a treatment for it. And then the patient just dangles and copes, and sometimes symptoms multiply, and they become sicker and sicker from all the other illness, all the other issues going on, the accumulation of post-exertional malaise symptoms, and then the things I want to talk about next. Okay. So I'm going to move on and say I still believe pacing is the single most effective way to minimize disease symptoms and to maximize healing. That doesn't mean doing nothing, though. It's really about understanding trying to understand, using the example of those gene expression studies, the severity and amount and duration of post-exertional malaise that occurs in you depending on what activity you do. So let's move on. So, and we don't have to spend as much time on these, but I do believe that there are aspects of the illness that can be addressed supportively, and if you don't address them supportively, they can unravel you and make the illness worse. And we're going to start, these are not necessarily in order of priority. In fact, the priority order depends on the individual. So I have people come in whose worst problem is orthostatic intolerance, or their worst problem is horrible sleep disruption, or they have pain that's just, keeping them awake and causing them severe symptoms, or people who've just become overwhelmed by their grief and despair. So let's just go through them a little bit. Of course we know, let's talk about the mental health and cognitive symptoms first. We know this is not a mental health disorder, but research suggests that mental health concerns commonly impact people with ME/CFS. You don't even need the research. We know that. There's a psychological impact of severe chronic illness. So we need to address this right up front, seek whatever is needed for support. And I'd like to add that, this is an illness probably centered in the central nervous system, in the brain, and that contributes also to cognitive impairment, which I like to think of as mental fatigue that parallels the physical fatigue. And the mental fatigue of this illness responds to the same things the physical fatigue does: pacing, good sleep, treating orthostatic intolerance, having better cognitive fitness, and not overdoing the medicines that fog the brain. I wanted to note here that stimulants may help in some patients with focus and concentration, but usually don't dramatically extend activity tolerance, and they don't prevent post-exertional malaise. So you have to be quite careful, and individuals have varying response to the use of stimulants for treating the fatigue. So here's coming back to our slide, our physiology slide, tying in why I think addressing mental health is important. So we have research about the HPA axis. We have many brain imaging studies and abnormal neurocognitive studies that suggest the central nervous system is critical and integral to this illness in terms of sensory symptoms of pain and fatigue, cognition, mood, sleep. And these interact with the HPA axis in your circulatory system. And emotional stress is a stressor that can activate and alter immune function and the HPA axis and the autonomic nervous system. So I just include this slide coming back to what we're thinking of as the multi-system nature of this illness to say that supportive care is not a Band-Aid. Supportive care is addressing the major aspects of illness cautiously and carefully to reduce and minimize symptoms. So the second to talk about here is the orthostatic intolerance, and we have a lot of research that supports the presence of heart rate and blood pressure dysregulation that contributes to symptoms and low function. There's the literature on POTS, orthostatic hypotension, neurally mediated hypotension, and these are just variations on a theme we often lump under orthostatic intolerance. We have studies to show there's low volume, autonomic nervous system, and hypothalamic pituitary adrenal axis dysregulation, all of these areas of the body contribute to the ability to have your blood pressure and pulse pump the blood around your body, up to your brain, out to your limbs. And we don't really understand the causes and the physiology very well. We know pieces of it, and we can measure it in some ways. But we know that it's worsened by dehydration, heat, prolonged upright posture, overexertion, and many of the things we've talked about that can make it worse. Again, here's our diagram showing how orthostatic intolerance is a very integral, important part of both our research base of the autonomic nervous system, tilt table testing, cardiopulmonary testing, blood flow, neurocognitive tests, impacting multiple systems in the body. So I know not everybody has the same degree or nature of orthostatic intolerance, but these are some of the measures we can use. You can talk to your doctor about this. The traditional is blood pressure and heart rate assessment, supine, lying down, that means lying flat and resting there long enough until you're very settled, and checking both the blood pressure and a heart rate in the supine position. Then compare that to what the blood pressure and the heart rate do when you've been standing in one place for 3 minutes. This is the standard, not 30 seconds, not 1 minute, 3 minutes. That is a long time to stand in one place. And the criteria for orthostatic hypotension are a drop in systolic blood pressure by 20 points, and for POTS, it's an increase in heart rate of 30 points. And it depends. There's a little bit of variation in the literature, but the point is there's a big shift when you move from a resting supine state to a standing state. It's as though the physiology can't support that change, and it may relate to multiple factors: volume, the autonomic nervous system, hormones, and other factors. We can do tilt table testing. I find it very difficult to find tilt table testing. I no longer have access to it in Salt Lake. I'm sure that it's difficult in most places. It's not very well reimbursed. So I've started to use other more simple measures to try to get an assessment of how important orthostatic intolerance is for a given patient. One is just your tolerance for standing. How long can you stand and wash the dishes? Most people.
Cindy? Chris, can you hear me?
Yeah, I can hear you, but I can't hear her.
Okay. Let me let her know that we can't hear her. She just dropped off.
I'm trying to see if she's still on.
Looks like she's still on. Oh no, it says she's gone offline.
Oh.
Okay, bear with us, everyone. I'm going to give her a call. Hey, Chris, while we're waiting, can you tell everybody about the recording?
Yeah. We are recording the webinar tonight, and we are hoping to get it posted on our YouTube channel by tomorrow afternoon at the latest. Each of you who attend will receive an email letting you know how to find it. So we'll get that for you as soon as we can. And Suzanne is working, trying to get her back on.
We have hours of vertical activity. This patient, yes.
Cindy?
Suzanne, yes.
Okay,
Cindy,
this is
you've
Chris.
been gone for
a
while.
Yeah.
Am I back now?
You are back
Yes.
now, loud and clear. Can you back up a slide?
Yes.
Yeah, so I think you cut out right when we were talking about testing people's orthostatic intolerance by how long they could stand.
Okay, good. Well, we haven't missed much. Next time you call me, text me though, because I felt like I couldn't answer my phone.
Okay, okay.
All right, so that's perfect. So what I was saying is that what a new measure I've been using in the office to try to get a sense of how significant the orthostatic intolerance is for a given individual is what I've termed hours of vertical activity. This is basically upright activity when you have your feet on the floor. That includes sitting. So sitting, standing, walking, versus lying down essentially. So sleeping at night or lying down to rest and recover. And what I've discovered is most of my ME/CFS patients typically have only 2 to 8 hours of vertical activity in 24 hours compared to, for example, my fibromyalgia patients who are able to be upright a more substantial period of time through the day. They may not feel good, they have a lot of fatigue, pain, but they're able to sit, work on the computer, do things a lot longer than many of my CFS patients. And here is an example of a clinic note similar to the one you saw. This is the pain diagram showing this person has a lot of pain in their limbs. I think it may be related to their severe orthostatic intolerance, fatigue, and sleep problems. But they only have 4 hours of upright activity, sitting, standing, or walking in 24 hours. And most of the time, this person spends horizontal. This person had severe POTS, postural orthostatic tachycardia syndrome. And when we were able to treat the POTS, a lot of this peripheral pain improved because those peripheral blood vessels were clamping down to increase core circulation. Once we were able to address the worst problem she had, which is orthostatic intolerance, most of her other problems improved significantly. And I wanted to show this slide. I do it cautiously, but I think it's very dramatic. This is a patient who came, this reflects the symptoms of one of my patients, a 46-year-old male, who we treated with IV fluids. And this date right here, September 2004, his symptoms, these are his symptom scores. I did not gather these scores until after this was all over. I went back to my clinic notes to look at his symptom scores, and this is the key right here. So he had a 10. His sleep was severely impaired. He had an 8 out of 10 on body aches and very bad fatigue, 7 out of 10. Not so much cognitive, and his mood symptoms were not significant. We gave him let him take some IV fluids. When he came back in, they were a little bit better. The next visit, he stopped doing it, and you can see his symptoms went up. And at this point, we put a PICC line in him, which is a permanent IV line, semi-permanent, that's there for very many months. He took a liter. We gave him a liter of IV fluids every day, and you can see for the next year, his symptom burden stayed very low until he had a PICC line infection and a blood clot, and we had to take his PICC line out, and his symptoms started to go back up again. Now, there are some published data suggesting that increasing volume is helpful. I believe that it is. I put this in here to demonstrate how important it is to address orthostatic intolerance, but I want to tell you that any kind of IV access, an IV catheter, a short catheter, a PICC line, eventually results in some kind of a very significant medical complication, including infection, sepsis, blood clots. So I do not advise that people put a permanent line in and get daily IV fluids. However, I do encourage my patients at any time that they're not doing well to access IV fluids and use them liberally as a means of improving temporarily. So the treatment of orthostatic intolerance must definitely be individualized based on whether it's even there or not, what kind it is, how severe it is, how old the patient is. You can't treat an older person with high blood pressure and hardening of the arteries the same way you can a 24-year-old who has these kind of issues, and other comorbid conditions enter in. If you have orthostatic intolerance, you should seek help from medical providers, learn as much as you can about it, and then utilize IV hydration, fluid hydration, mostly oral, IV when you can get it with it safely. Salt intake, if you're not hypertensive or have fluid issues, again, you have to take this based on your comorbidities and other things going on. Pay attention to medications, either that help or that cause more orthostatic intolerance. Work with this with your doctor. I have patients who have very good success using compression clothing to improve their function, reduce their symptoms. Definitely, the better fit you are, the more muscle tone you have, the better you challenge your cardiovascular system, the better your orthostatic intolerance will be. And last but not least is you can recover in the horizontal position. So you should periodically, if you have severe orthostatic intolerance, get in that recovery position, hydrate, rest, while you're alternating with other activity. So I need to keep moving, but they won't each take as long. The next area of supportive care that is really pivotal for maintaining better stability with this horrible illness is pain management. And here I have a slide demonstrating, really severe widespread pain from one of my patients who ranks her pain as a 10 out of a 10. Pain, as you can see from our multi-system diagram, is integral to this illness. It's centered in the brain in some aspects in terms of an escalation of pain signaling that we have learned from fibromyalgia research. It can impact the musculoskeletal system. There may be an inflammatory component, and it can impact headaches, GI pain. Almost every aspect of the body can be impacted by pain escalation. And it's not really clear how much of it's neurologic, how much of it might be hormonal or related to inflammatory and infectious pathways. Maybe a combination of all of the above. But when pain is severe enough to become a stressor, it disrupts all other aspects, makes you tired, disrupts sleep, makes you moody. So it's important to address and treat to the degree that it can be treated. Pain can be manipulated by a number of things. There are medications that might be helpful in improving pain. You've heard about most of them, I'm sure, the fibromyalgia medicines, muscle relaxants, drugs that impact opioid receptors. And we've learned from a lot of fibromyalgia research some tools that we have that might improve pain. They are not for everybody. Sometimes the medications add worse symptoms depending on the patient. But there are the things that help pain. I believe there's a significant improvement in pain when you achieve good restorative sleep patterns. To a degree, being able to be more fit helps with some aspects of pain, not like stiffness and immobility. The studies in fibromyalgia show pain does not go away when you're more fit, but there are aspects of the pain that become more tolerable. You can certainly jack up the pain by doing too much, so you have to be careful not to cause pain amplification along with a part of post-exertional malaise. And then many mind-body interventions are very, very helpful for pain management, and everyone should learn how to relax, meditate, relax all those systems in the central nervous system to try to give the brain respite from all of the upregulation and stress. What about sleep? When sleep is corrupted and non-restorative, it becomes an important aspect of the illness that should be addressed, and if addressed, it can improve symptoms. And this is not a Band-Aid either, right? We know that sleep is regulated in the brain. It's influenced by the HPA axis. Sleep is also related to other illnesses, right? Depression. We talked about pain, getting up frequently to urinate, restless legs. There are many factors that can disrupt sleep. And there are many abnormal sleep studies and other studies that support this is an integral part of the pathophysiology of the illness. Non-restorative sleep is probably one of the most common complaints I have from patients, other than the global reduced stamina and fatigue. I think it's one of the least well-studied aspect of the illness and understood. We don't really understand why it's problematic. It can be very, very difficult to treat, and sometimes we overkill in trying to treat it. Too many medicines, too much focus, too much worry about sleep can actually unravel sleep. So I usually try to use the least medication possible. Try very hard to understand what's contributing to your own sleep disruption, what the causes are. Is it pain? Is it movement of your muscles? Is it problems with your breathing, racing thoughts, urinary frequency? And if you use a medication, try to direct it specifically at the thing that's disrupting sleep without having so much medication that it starts to destroy normal sleep architecture and cause daytime cognitive symptoms and fatigue. And the goal should be to work toward behavioral management of sleep. That means getting better sleep because you're going to bed on time, you're not doing things that make your sleep compromised, and getting better and better at managing your sleep without heavy medications. And last, I wanted to say something about fitness, which is obviously a challenge due to post-exertional malaise, which we demonstrated thoroughly in the first part of this talk. But there's no doubt that fitness makes a difference. It's true with every chronic illness. It's a controversial topic, clearly, but if you can develop muscle tone, improve your cardiovascular fitness without causing post-exertional malaise symptoms, it will have benefits to our sleep, mood, stiffness, fatigue. It reduces that frailty and physical limitations that come from never moving and losing all of your strength and conditioning. So it's something that each person needs to examine about their own illness and find out for you what the best tolerated activities are. And my opinion is, I put this, basically, and you'll have to adapt this and learn, but I usually tell my patients to do very short intervals and low intensity. So don't do anything too long and don't do anything too hard or intense, because you push those bars up and that we saw in the gene expression. And I usually tell people to only exercise 3 days a week, alternating with rest days. So exercise on Monday, Wednesday, Saturday or something, so that you have a chance to rest, observe for post-exertional malaise, and make sure you're doing okay, and revise what you're doing day by day, but depending on how ill or how well you are. I think exercise that's done seated or lying down or in water is better tolerated. You can get more out of it without having post-exertional malaise symptoms, and particularly in water, because you're in a pressure tank. There's no impact on the joints. It's helpful for pain. You get kind of global resistance, and your blood pressure doesn't drop when you're in water. So if you find access to water, that's a way to improve your deconditioning. And you want to have a combination of staying flexible, making sure all your muscles are toned and strengthened a little bit, and putting your heart through a little bit of the same thing. You want your heart rate to be up just a little bit and stay up, so that your heart muscle stays strong. Now, for people with POTS, that might not be an issue. They've got a lot of cardiac exercise. So each person needs to examine their own fitness and how they can gradually improve how they feel. So I put this slide near the end of the talk to remind us that what we really, really need is to treat the primary aspects of this underlying multi-system illness. But realistically, these treatments are expensive, even the ones that are experimental, available to some people, such as Ampligen or Immunovir, intravenous immunoglobulin. You've all probably heard a little bit about studies using Rituxan and other immunomodulators along with antivirals, and these medicines may teach us about the illness. We may find some people who respond, but on the whole, they're not accessible to the majority of people who are out there and ill, which is why the focus of this talk has really been about what can you do until we have better tools for understanding and treating the primary pathophysiology, including not only these immune drugs, but drugs that might support different aspects of the HPA axis. Hormone regimens need to be studied for sustained efficacy and long-term safety and outcomes. And I'm putting this in there because I know there are many providers out there supplementing cortisol and many other hormones, and I would just caution all of us to say we really need to understand a lot more about the illness and continue to understand how the HPA axis plays a role in this illness. So here again, just to sort of close, we have our large diagram of ME/CFS as a multi-system illness that involves neuroendocrine, that's hormone factors in the brain, immune mediators, neurotransmitters, and goes out to affect many different pathways, sensory, immune, the sympathetic nervous system, neuroendocrine pathways in the body, all of which are supported by a growing database of research which give us information to guide our clinical management. So we can address the known physiology based on clinical intuition and established research. So that's really the end of my talk. What I would hope to leave with you is I would like you to feel empowered to assess your own illness, take these pearls of management, very practical management, to your primary care doctors and to the team that you work with, and see which ones apply to you and how you can achieve best management.
Bravo, bravo. Applause is being heard around the country, Cindy. That was an outstanding talk. Very encouraging, very enlightened. It's just good stuff. We have a bunch of questions. We have time to maybe ask a few of them, or I'll ask you a few of them. And this is one that I actually had in the beginning. Can you use the gene expression studies to help inform your treatment strategy? So, for example, prescribing beta blockers. Is that some way that you can actually use that molecular gene expression information?
I would like to say that we can, but honestly, even among my own patient population, a very small percentage of my patients have actually had gene expression studies. So although I'm enthusiastic about them, I do think we need to learn a lot more about what those individual gene expression messages are telling us before they can actually guide our treatment decisions. Now, I do think that the area of autonomic dysfunction, orthostatic intolerance, might be the first place to start because of some of the information we have from gene expression. But truthfully, in the clinic, I rely more on those bedside measures, people's vital signs, the orthostatic measures, their hours of upper activity, their age, their comorbidities, and then I start to design a treatment regimen and a little bit by trial and error decide about whether we're going to use low-dose beta blockers or something that controls blood vessel tone or along those lines. And I coach everybody about fluids and hydration and compression hose and conditioning. So we're just very, very early in this, but I do think gene expression has promise to give us a lot of information down the road. I think we need to stick with it and do more studies in more people across more time points so that we understand what the message is. Clearly there's an illness going on. Clearly it's triggered by exercise. Now we need to decide exactly what it is it's telling us and how we can apply it to management.
Mm-hmm. So you mentioned exercise quite a bit, actually, and you mentioned people not going into a post-exertional malaise state, that being harmful. So how do we understand graded exercise then? What is really meant by graded exercise?
Well, I mean, I see in the studies graded exercise to mean that you should start at a low level and push yourself gradually up and up and up and up until you're strong or well. I think that's kind of the implication behind the term graded exercise.
Okay.
I don't particularly like that term. I don't think people should engage in that kind of an exercise program when they're severely ill. Well people should, deconditioned people should, what I'd like to see people do is minimize their deconditioning as much as possible to minimize the impact on illness. So that might mean simply getting up more out of the bed and walking around the house for some people for very short periods.
Mm-hmm.
It might mean some people are able to do more than they think. You know, I've learned from my patients, not from me telling them what to do, but that from them coming back and telling me, you know, I discovered that if I did this and this and this, and I was really careful and I watched for post-exertional malaise, I was able to achieve much more about my fitness than I thought I ever could. I've learned that through my patients.
Mm-hmm.
Everyone tells me that the stronger they are, the better they cope and manage their illness. The trick is getting there.
Right.
So I think it's quite difficult for someone on the outside to give you direction as a patient, except to encourage you. And I do believe this is an illness that largely has to be self-management. And so what the message from this talk is, you know, don't give up. Don't fall down in a heap. Don't let the symptoms overwhelm you. Rearm yourself. Get back up. You know, observe. Use the tools we have to do the very best you can to achieve a better quality of life and symptom control using some of these tidbits and other tidbits you learn from others and from your own experience. But conditioning is one part of that.
Yeah. There's a couple of questions about some other symptoms that you didn't touch on, but that we know are pretty common in people with ME/CFS. What advice do you have for people who suffer from chronic sinusitis?
Well, I'll tell you an anecdote, and this is not the answer. The answer is there are many answers to that question, okay, and I'll illustrate that with an anecdote. I had someone come in, and I'm not going to tell you the particular regimen, but we were able to achieve a much better volume state and treatment of orthostatic intolerance with a set of interventions. And I was completely shocked. This person said, the best improvement I've had has been in my sinuses. And I'm like, okay, let me figure that one out. And I think that she had better hydration of her sinuses because she was in a better hydrated state. So she drained better, had less thickness and dryness of her sinuses, but I was a little bit surprised. So you know, something like chronic sinusitis might be infectious, it might be inflammatory, it might be allergic, it might relate to a lot of other factors. There are medications that alter blood vessels in the nose and make your nose swell up. So each of the problems in this illness need to be addressed in a multi-system way. And I do think sometimes we hammer at one thing, like with using this example, antibiotic after antibiotic after antibiotic for sinusitis when it's really not an infection that's causing the problem.
Right.
So that is a challenge, working from the immune standpoint, the blood flow standpoint, the inflammatory standpoint, as well as the idea that it might be an infection.
So how do we clone you? I mean, obviously, you know, you have a great deal of expertise and experience and passion for ME/CFS patients, and many patients in our community are homebound. They don't have access to caring physicians like yourself. How do people that are either homebound or can't come to people like you, how do they get care, like the care that you just described?
I don't know, except for I think the message, most of the time my message when I'm speaking is to try to just implement a practical approach, which is find the best primary physician you can, and by best I mean someone who will listen to you and talk to you and work with you and is available, maybe a little bit open-minded. Work with them, train them with good communication, and get a small team of people you trust, whether it's a couple of specialists or allied health professionals, or mid-level providers like a good nurse practitioner. I think many people get really great management from a nurse practitioner or a PA who's willing to spend a little bit more time and ask questions and read things. But it really has to be, right now, it has to be that interface between the patient and a primary level provider. And I do believe most of what I've just talked about can be implemented on that level. Just taking it a piece at a time, trying not to look for, one hammer to hit everything, but just systematically assessing your own disease state and how each of these factors might be improved a notch. And don't forget step number 1, which is to have a team that will constantly reevaluate what the other contributors to fatigue might be. Because sometimes someone comes to my office, they go away feeling so wonderful, all we did was clean up their other medical problems that everybody had been ignoring.
That's a very good point. I have actually, over the past several months, suggested to a number of patients that they look into some of the integrative care centers that are now, I think there's at least 25 of those around the country, either at teaching hospitals or affiliated with some of the bigger HMOs, because I think the healthcare system is now realizing that many of our chronic maladies are in fact quite complex and need time and understanding in order to begin to dissect them down.
Right. Yeah, it's very important to have your team understand that you're ill. They don't have to understand exactly everything that's been published about CFS. They don't even have to buy into it. They just have to believe you're having real experience and that you're doing your best and you're having all these symptoms, and they can team with you to work on them. I mean, one of the problems I have is people want to come see me, but I'm no better at curing CFS than anybody else, right? This is a horrible chronic illness we haven't been able to conquer. I can't cure CFS. What I can do is offer good supportive care, help people make the very best decisions and take advantage of everything we have to be the least sick possible until we can make better sense of this illness. That can be done in other settings. It's just that medicine's evolved to a place where it's a little bit impersonal and quick and cynical, and you got to work around that. You got to connect with someone who doesn't buy into that too much.
Yeah. Yep. I think that's changing too. I think it's now the realization that the paradigm does have to shift towards figuring out how to tackle these chronic illnesses in a integrated manner that is helpful, because it's much more helpful to have people feeling better and functional.
Yeah. And the idea of sometimes the medical profession seems very judgmental, and I think the one thing we do pretty well here in our clinic is we just accept at face value that people are struggling, right? And I really believe that if people feel better, they just get better and go on, right? It's very rare that people have a lot of secondary gain from being ill. But there is sort of an aura in the medical system that, they distance themselves from this very difficult problem by blaming it on somebody else. But you know what? You just got to work around that and associate with people that you can communicate with and develop a good relationship with.
I think on that note, I would like to thank you again. You've actually held everyone's attention for the past hour and 20 minutes. It's phenomenal. We've had over 350 people listening and asking many questions. Chris has been relaying me the questions, and I've pasted them into a document which is now about 10 pages long. So we have our work cut out for us in addressing some of these. We have actually addressed many, and what Cindy and I will do is get together and we'll take a look at these, and then we'll put something together and post it on Research First so that everyone's questions will be addressed. And again, this webinar has been recorded, and we will have it posted to our YouTube channel probably by by the beginning of the week. It may even happen this weekend, and we will send out an email blast letting everyone know what that URL is so that you can listen. And we will also let everyone know when the blog has been posted addressing all of these great questions. Cindy, I'd like to thank you very much for your time on this Friday afternoon. It's now time to TGIF.
Great. Thanks, everybody. Good luck, and hang in there.
Thanks, Chris. Good night, everybody.